Hi, everybody. This is Professor Dunham, and today I'm going to discuss Chapter 12, the term newborn. So please open your books and go to Chapter 12, and we're going to do something different this time. I'm actually going to read to you the questions on the unfolding case study. And so I'm going to start off with the following question. So what are the general principles of care of the newly circumcised penis that the nurse can explain to the mother? So write that down, write down the term circumcision. So as we discuss things that you can make your notes. Okay. Then the next number 2 is, what can the nurse tell the patient about the normal changes in the appearance of the infant's stool, just she will see the next week when she's at home? So write that down. What's the normal stool that you've seen in a normal newborn, term newborn? And then number 3, what will the nurse tell the patient about the care of the umbilical cord when she's at home? So write down umbilical cord. And how should test the patient modify the diapering technique when the umbilical cord stump is still in place? So when you still have the umbilical cord in place, there's a certain way that you need to diaper the baby. So put that down. And then the next question is, the patients worry about that she will not have enough breast milk for her twins. So how can she tell if the infants are receiving enough breast milk when they're discharged home? So put down breast milk, and how does a mom know if she's feeding her baby adequately? And then the last one is, the patient states that the baby's cold because she sees his chin quiver and his hands a little bit blue. So she wants to delay bathing the baby. What can the nurse teach the patient about her baby's quivering chin, his hands are blue, and how often baths should be given to newborns? Okay, so that kind of gives you a little idea of maybe what to expect in this chapter. So let's go now back to the beginning of the chapter, and that's on page 284. And there's your key terms. So again, your key terms are so important, and I want you to go ahead and write them out and to look them up. They're right in the chapter. Okay. So as I always said, that the newborn's biggest job after he's delivered is to breathe. Okay, so write that down. What we call that, we call it an adjustment to extrauterine life. All right, so we need to breathe. So let's go ahead and discuss about that. So basically, this adjustment to extrauterine life depends upon his genetic background. Okay, if everything went well during the pregnancy and there's no problems, then he should do okay. All right, that's what we want to know in the very beginning. Remember that initial assessment, the initial visit that we did on our patient. We went over mom's and dad's history so that we would know if there was going to be anticipate any problems at birth. We're always thinking from the beginning of pregnancy, what's going to happen at the end when she delivers. Okay, so let's go. And we always want to make sure that not only the life inside the uterus was conducive to growth for the fetus, but also now as you labored her, you want to make sure that she had a nice, safe delivery. Okay, so we labored her. If we saw any kind of variable decelerations, we reposition mom, gave her oxygen, and baby recovered. That's why fetal monitoring and learning how to look at that monitor and decipher out if there's any problems going on is so important. Okay, and then of course, any kind of medication that mom got during labor. Okay, that's why we have to know the stages of labor and what is appropriate, what kind of analgesic or anesthetic the mom can get. Okay, in order that the baby is not sleepy at birth. All right, now when you're observing the newborn, the nurse identifies expected normal findings. And let me tell you right now, please know the normal vital signs of the newborn. Normal vital signs of the newborn. And you can look right in your HESI book, and HESI does a good job. Okay. It's always good to know the norms, because why? Because then you can recognize the abnormals. Okay. So go look on your in your book on chapter 12 in page 285, and you see phase 3, care of the newborn. Okay. So we're going to discuss some reflexes because those are important. That's part of the nervous system. And we got some reflexes. And now you got you got some you got the Babinski reflex, you got the Morrow reflex, you got the gag reflex, and you got the head lag. So you can basically read that in your book, but let me just tell you, these are reflexes that we look at when babies are born, but there's also different the other reflexes for a full term. Okay, and that would be blinking, sneezing, gagging, sucking, and grasping. And these what we call reflexes that keeps the infant alive. If you think about it, gag reflex, sneezing, blinking for the protect the eyes, grasping, and sucking. He needs to suck, have that reflex to suck in order to what? Take in the breast or the bottle to live. All right, and then you got some nice figures. Figure 12.1 shows you the head lag, and 12.2 the grasp, how he grasps onto what? Mom's hand. And then you have the other ones, you have the Morrow reflex. And what happens is that when the baby's crib is like hits against a wall or something, the baby goes up. He kind of like gets what we call the startle reflex. And so these are different reflexes, again, will help protect the infant. All right, so let's look on the next page, on page 286. Then you got the tonic neck reflex. So the reason why these are important is because infants that are born without the reflexes, we have to take note, because then there's something wrong with the neurological system. So on page 286 in your book, table 12.1, you have the ages of appearance and disappearance of neurological signs that are unique to infancy. And I want you to go down and start the Babinski reflex, because you'll probably see this one again. And how you do it is you stroke the sole of the foot, the big toe will dorsiflex, and the toes will what? Flare out. Okay. Now this is appearance at birth, and it disappears. Well, usually it disappears when the baby starts walking. Okay. This is the only time that you can have a positive Babinski reflex and be okay. All right. And then the other ones I did talk about a little bit is the Morrow reflex. And that's a loud noise, bumping the surface of the crib, like I said, or suddenly lowering the infant's head. He gets startled. Okay. And then you got the tonic neck reflex. This one's a little different because if you notice the figure 12.4, it shows you how the baby's position. So you turn the infant's head to one side, and the arm and leg will extend on that side. And then with flexion of the, while he's having flexion of the opposite arm and leg. Okay. And then the palmar grasp, you place the object in the hand of the newborn, and he or she will grab onto it. Okay, those are all, again, all very, very important reflexes. And then you have your other reflexes that are very much for survival. Is your, like I said before, is your blinking reflex. So the baby, what he does, he blinks on hearing a loud noise. Okay, all right. It actually protects your eyes. Then you have reflexes of your vision, eye opening, blinking to a threat, horizontal, vertical. And then you have what we call food reflex. And the first one you can see is rooting. And the rooting is the infant's head will turn in the direction of anything that touches his cheek, because he knows that he's going to eat. Okay. And then sucking, the infant will suck on a finger or nipple placed in the mouth. Then you know he's got a good suck. Okay. And then there are other signs that, I remember doing this reflex in front of my mom, and she goes, "Oh, my baby's so smart. She can walk already." No, this is called a stepping or dance reflex. So what I do is I hold the infant upright above a table, and he or she will lift his little foot up and get contact with the firm surface on the table. So they hit the table, the little foot hits the table, and what? His reflex is to come back up. And so he looks like he's walking, but he's not. Okay, so the next page shows you how to take head and chest measurements. Okay, so this is in the care of the newborn, and I did put a video on for you to see how we actually do measure the head, but I'll go over with you. So the circumference, excuse me, of the head is measured from the top of the eyebrow to the widest part of the occipital. Then, so you can see how she's doing. Just above what? The top of the eyebrow. So highlight that, because you may have this in lab where you have to demonstrate it. And then to attain the size of a fontanelle, you measure the widest part of the width. Okay, and remember, he's got two fontanelles. He's got the anterior and the frontal. No, frontal, excuse me, or anterior and occipital. Okay. And the normal anterior fontanelle in a newborn measures about 3.6 and 6 centimeters. So the fontanelle should appear flat with the contour of the skull. Now, highlight this or write this down. A bulging fontanelle may indicate increased intracranial pressure. A bulging fontanelle is not good. Now, because there's too much pressure in the cranium, so it kind of pushes that fontanelle upward, okay? So it's bulging. That's not normal. Okay, on the other hand, if you have a depressed fontanelle, that is not normal. A depressed fontanelle may indicate the baby is dehydrated and should be reported to the doctor, okay? So a depressed fontanelle means he's not getting enough fluid, so it's down, okay? He's dry, okay? So please write those two terms down, okay? Now we're going to measure the chest. You take the measuring tape and you place it at the nipple line, as you can see in the page here. And you lift the infant to remove the paper tape in order to prevent paper cuts. Yeah. Do not take a paper off anything underneath the baby. Just pull it, because you'll cut the baby. Okay. Their skin is so fragile. And then what you do is you document your findings and report any abnormal measurements. Now, this is kind of important. It's always nice to know that the head circumference should be equal to and no more than 2 centimeters greater than the chest. Okay, so the head circumference should be equal to and no more than 2 centimeters greater than the chest. Okay. All right. And that kind of goes to he's about age 2. All right. So that takes care of how you gotta measure. And look on page let's go to page 288. Yeah, 288, sorry. And here you've got some molding. Now, write that term down. So what happens, remember I told you baby's skull has soft tissue, so is able to conform to mom's pelvis. And so, baby's had to come down that passageway, remember? Sure. So when he does, sometimes if he's down in the pelvis a very long time, say, he can mold or conform to mom's shape. And so as she labors, his head is being pressed against mom's pelvis. So that's called molding. Okay. And a lot of ladies, the babies sometimes are low in the birth canal, and they have a lot of pressure. Well, that does help her labor, But when he's in that birth canal a long time, this is what happens. Okay. Now, I also, there's another term called caput succedaneum, and I had mentioned that to you already. And what that is just swelling of the soft tissue of the scalp. Okay. And what it is it does go away without any kind of treatment. Moms go, oh my goodness, look at my baby, but it's okay. Now the caput succedaneum does cross the suture line, and because remember I explained that to you before that the caput succedaneum is usually back in this area of the head, and is the head been down the pelvis, and so it's kind of like all smushed, so it gets some swelling underneath the scalp, and you see my suture line runs right through the middle of the head, right? So you can see where caput succedaneum would cross the suture line. Okay, and then you might have, well, remember I told you too about a sepal hematoma. Okay, so sepal hematoma means what? Blood. Okay, and so it's a collection of blood under the scalp, and that will go away too. Now it's usually on the side of the head. Okay, so that one does not cross the suture line. So again, where is it? So I'm pointing to my head, and it's usually on the side of the head. One side or this side, or it could be both sides, according to what's happened, but it's a collection of blood underneath the scalp. Well, it does go away, but when it gets absorbed by the baby, it can cause the baby to have what we call hyperbilirubinemia, which then leads to what? Jaundice. Okay. All right. So those are the fontanelles. And just to let you know that the anterior fontanelle is like a diamond shape. And it's located, I kind of told you where it was, right in the front there. Okay. You have the peritoneal on both sides, and it's right in the middle of that, of the frontal bones. Okay, then you have the posterior, and that looks like a little crescent. And that's between the occipital and the peritoneal bones. Okay, it's the back of the head. All right. And so you got to make sure that you just tell mom, do not, don't put any pressure on these fontanelles. Okay, they have to close properly. All right. So now let's go on. That was the head, and there's some good pictures in your book. As you read, you'll see these. All right. And then we'll go on to the eyes. All right. So a healthy newborn can see, and they can fixate on points of contrast. So the newborn shows preference for observing a human face and following moving objects. So therefore, visual stimulation is an important ingredient in a newborn's care. Like toys that make sounds and have contrasting colors attract the newborn. So those little mobiles that you use on top of the crib, and they have colors and they go around. Well, that's what keeps them their attention. Okay. And most newborns appear cross-eyed because their eye muscles are not fully developed. Okay. At first, the eyes appear to be blue or gray, and the permanent coloring becomes fixed between ages 6 and 12 months. That's what a lot of people ask you, by the way. They want to know, my baby's eyes are blue, but there's nobody in my family that's blue. They get kind of panicky. And that's where you have to tell them that at first, the eyes appear to be blue or gray, but the permanent coloring becomes fixed around age 6 to 12 months. Okay. All right. Let's go down to ears. Now, ears are, are well developed, but they're small at birth. Okay. And the ears, we assess for placement, because a low set ear may indicate a congenital anomaly in the another part of the body. So we want to make sure that we check the ears. And then you have this like imaginary line drawn from the outer canalus of the eye here that should be what? Should be even with the upper tip of the ear. So you take your outer portion of the eye, like right here, I'm showing you, and draw the imaginary line. It should come back to the tip of the ear. So you can see mine are good. All right. All right. Hearing is important to the development of normal speech. So therefore, every baby gets a hearing test, And on page 289, figure 12.7, you can see that the newborn hearing screen has an immediate pass or fail. Okay. And so if they don't do well, then they're going to get sent out for a specialist. Okay. Because again, babies need to hear. Now, you can kind of tell if your baby can hear is in when you're holding the baby and say there's a loud noise in the room, the baby should what? His face should go toward that. His head should turn. If mom's talking to baby should be have the attention on mom. So that's how we actually can tell babies can hear. And it's kind of nice for the mom to experience that. All right. All right. Let's jump over to sleep. All right. Now, sleep is important because it gives mom some time to rest too. So she doesn't remember the postpartum blues and postpartum depression. Baby's not sleeping, right? Mom has to stay up all the time. Mom gets tired. So sleep. So the neonate, and it's considered a neonate. It sleeps about approximately 15 to 20 hours a day. There's a gradual change in the quantity and quality of sleep as the newborn matures. So at birth, say, the newborn passes through the phases of sleep-wake stage as part of the adjustment to life outside the uterus. So the first reactive phase is during the first 30 minutes of life. I think we talked about this already. So the newborn is alert. And at this is the best time to like initiate bonding, between the parent and the newborn. Okay, so that's like the first 30, sometimes 60 minutes of life. Okay, after that, he gets really tired. So then you go into the sleep phase. And then during the next few hours of life, the infant gradually becomes sleepier and less responsive. He's tired. And second reactive phase, okay, so that's a sleep phase. Okay, so remember I told you that was a good time that after all the excitement's over, the L&D nurse will take care of mom and make sure her bleeding is okay, she's not hemorrhaging, and get her all cleaned up to take her out to the mother baby unit. The baby will go to the nursery, and daddy can go with the baby to nursery to see what they do, and they can check out the baby a little more. All right, then the baby goes through a second reactive phase. After a deep sleep, the infant again becomes responsive and alert. So what? So now the baby is taken back to mom, and mom now is on the mother baby unit. All right. Then you have the second reactive phase. So after a deep sleep, the infant again becomes responsive and alert. So now he's reunited with mom. Okay, I just went over that. All right. Then stability phase. After 24 hours, the sleep-wake pattern becomes more stabilized. Then the pattern of sleep gradually develops into one in which the newborn now is awake and during the day and asleep during the night. Well, that would be nice. Okay. And this is where sometimes moms will need a little help when going home, is because this is a really nice pattern that he's awake during the day and asleep during the night, but sometimes babies get themselves backwards. And so mom needs probably a little help. Okay. So, and another thing too that helps a baby sleep is his environment. It plays a large role in the infant's sleep behavior. So the nurse can help the parent to understand that normal conversation tones can quiet a newborn, okay, whereas high noise levels can cause increased crying. So you don't want a house to be totally quiet, because then the baby gets used to that and he won't be able to sleep unless it's totally quiet. So you want nice, low, soft tones, but nothing high pitch, because then they get irritated because they don't know what's going on. All they hear is this loud noise. And then keep them snugly wrapped, because don't forget in utero, they had such a nice little environment, and when they and they were like encapsulated. So when they moved their arm, they could only move a certain amount, and then they were back to being snuggly, and they get used to that snuggle. Okay, so that's what happens. Okay, Now, we're going to talk about pain. All right, so pain. Pain, there's a different pain scales. And remember, babies do feel pain. So, in the past, it was believed that newborns did not experience pain because they felt they were immature and their nerve pathways to the brain were immature. But it is now thought that fibers that conduct pain stimuli to the spinal cord are in place early in fetal life. And we know them as neuroreceptors. So NOCI is pain, and of course, then receptus is to receive. So they receive pain. Well, yes, they do. And latest studies have shown that. So they have some pain scales, and they have, I just go ahead and take your highlighter and highlight like the following: the comfort scale, which that's a 7-point scale that includes when the baby's alert or calm, muscle tone, movements, facial tension, and respiratory response. And then 2 physiological items that are heart rate and the mean arterial blood pressure. And each item is scored like 1 to 5. Okay. So this is a scoring system. All right. Then you have what we call CRIES, CRIES, and that is a 10-point scale. And that's again has a score of 0 to 2. And this includes like facial expressions, crying, movement of the arms and legs. Is the baby able to be consoled, and oxygen saturation? So that's why we have it called CRIES. So the C, write down C, is equal to cry. R requires oxygen. Okay. I is increased vital signs, because remember, when your blood pressure goes up and your heart rate goes up, you're in pain, right? And then E, expression on his face. The baby's not happy. Okay. He's got a grimace. And then S, he's not sleeping, guys. It's got sleeplessness. But this is a pretty good one. I like cries because it tells you a lot about the baby, and babies do tell you a lot when they cry. And then if he's crying so much, he can't get his breath, so he requires oxygen. And then he's got, of course, increased vital signs, which you can equate that to a regular person. And then E, expression on his face. Well, when you're in pain, you don't have a happy smile. No, you're grimacing. And, it's obvious that you're in pain. And then, of course, if you're not sleeping, you're not sleeping because you're in pain. And so you need some help. So I like that one. And then you have FLACC. And highlight this one, this too. This pain tool measures the pain of infants. So this one has parameters. Yeah, your face, legs, activity, cry, and is the baby consolable? And we notice that because when a baby is not consolable, there's a problem. Okay, a lot of your babies that are born with the mommies that have cocaine, they're not consolable. And so again, you're going to look at all these. Okay, then you have the PIP, PIPP. This is for premature infant pain profile. So it's based on scale similar to the CRIES. And then this one rates the eye squeeze, the nasal labial furrow, heart rate, oxygen concentration or saturation, and the brow furrow on a scale of 0 to 3. Okay, and that's with the premature baby. It's a little bit different, but it kind of goes on the same premises as the CRIES. I told you I like that CRIES. Okay, then you have the NIPS, and that's the neonatal infant pain scale. And again, the scale similar to the CRIES. And this one, again, it rates the facial expression, arm movement, cry. So you can see what they're basing it on. It's mostly the CRIES. And then they have the NPAS, which is the neonatal pain, agitation, and sedation scales. All right. So these are all very interesting pain scales. And so we do take the consideration that pain in newborn is there. Okay, so you may know there is an example on the next page, figure 12.8, paying the newborn. You note that the furrowed brow, he's got his fists that clench, they're like clench, like this. Oh, he may be irritable or crying. His chin may be quivering, okay? And then he has increased muscle tone and activity. He's got his eyes closed tight. You see that baby there? And then his mouth is open. He may be diaphoretic, rapid shallow respirations, and increased heart rate and blood pressure. Okay, so you can see that that baby's in pain. Okay, so then you could use your cries pain scale with this baby, and you can see how much he needs some cuddling. Okay. All righty. So another thing I'll go over with you is the neonatal behavioral assessment scale. So again, what this is, it just increases the understanding of the newborn's capabilities, other areas of assessment. And this scale, it measures what? The neurological capacities of the newborn. Okay. Respiratory. All righty. Well, babies are born, with a lot of fluid. So they need what? They need help when they're born. So once that cord is cut, then they're on their own. So they need to cry in order to get the lungs to be inflated, because when they're born, they're not. Okay. And so the circulatory system has to adapt to life externally. Okay, so again, the circulatory system has to reverse itself than what was in the uterus. Okay, so the first breath helps to expand the collapsed lungs. Okay, I write that down. The first breath helps to expand the lungs, and we can do that. We can help them breathe by what? Removing the mucus. Okay. So we use a bulb syringe, and we get the mucus from the mouth and nose. Okay. Now, when you use the bulb syringe, and you probably did this in lab, is that you don't just go directly in the middle of the mouth. You're going to go over to the side and suck from the side. Okay. If you go in the middle, what are you going to elicitate? What are you going to start? You're going to start up the gag reflex. So you don't want to do that. So you want to make sure that you gently clear the mucus with a bulb syringe. Okay. All right. And it tells you right in the book, when this procedure is done orally, the tip is inserted into the side of the mouth. Okay, highlight that. And because in order to avoid stimulating the gag reflex. And the parents, you make sure that you teach them how to use the bulb syringe, and they're instructed to keep one next to the newborn during the early weeks of life. Yes, so that'll be part of your discharge. But what are you doing? Remember, discharge planning for newborns start on a mission also. So we're going to make sure that we teach mom and dad how to use a bulb syringe. And you want to keep the crib empty of any kind of little stuffed animal in the bed, because that would also interfere, and that little stuffed animal could fall right on that baby. Okay. All right. So now we're going to discuss an important aspect. It's called the APGAR score. Remember, I told you Dr. Virginia APGAR, she came up with this score in order to assist the healthcare providers, the nurses, respiratory doctors, how much resuscitative measures should be done. So we have 5 objective signs that are measured, and they're heart rate, respirations, muscle tone, reflexes, and color. Now, write that down. So 5 objective signs that we're looking at, okay? That we are looking at. All right, and they are heart rate, respirations, muscle tone, reflexes, and color. So we do a score 1 minute after birth, and again at 5 minutes. Okay, so what happens is that we want to make sure that if the baby's coming out and he doesn't have color, he's not giving a good cry, his heart rate is below 100, um, we got to do some resuscitative measures on this baby, okay? And the sooner you do it, the better you are at getting this baby back. So so that's the APGAR score. I would definitely, write that down, write out the 5 objective signs that we are looking at and how we score them. All right, let's go on to circulation. You know that the baby has approximately 300 mLs or circulating blood volume. Okay, so the circulation of blood in the fetus differs from that in the newborn, right? Okay, so remember, fetal blood bypassed the lungs when he was in utero. Okay, but now, guess what? So now he's got to what? He's got to breathe on his own. So what happens is some of the blood. Oh, sorry. Okay, so basically, he's going to be born and he has to reverse the circulatory system that he had in utero. Babies also lose a lot through their a lot of warmth when they're born because they have an unstable heat regulating system. The body temperature falls immediately after birth, but within a few hours, it will climb back up to a range of say 97.8 to 98.9. So what you want to do is that you want to keep the baby warm at birth. And we worry about thermoregulation. Okay. All right. So I would, there's a condition called acrocyanosis, and that's where the newborn's hand and feet, they're kind of blue. All right. And that's normal. So like if a daddy asks you or mommy asks you, why is my baby's hands and feet blue, you can tell them that that is normal. Take note to that. All right. Then I want to jump up right now back to bulb suctioning. And there is a picture on page 292, how you actually use a bulb suctioning. And this is used to clear the airway of mucus. Okay, so you compress the ball of the bulb syringe and insert the narrow portion of the bulb syringe into the side of the infant's mouth to avoid stimulating the gag reflex. Suction the mouth first. Write that down. Suction the mouth first to prevent inhalation and aspiration of mucus during a gas reflex, which is stimulated by nasal suctioning. So that's why you do the mouth first. And I told my students in the past to do, the mouth is bigger than the nose. Okay, so do the mouth first. Because what happens when you do nasal suctioning, you're actually going to elicit a reflex, a gas reflex. And whatever mucus is in the mouth, he could aspirate on the mucus. So you don't want that. You don't want to create that. So do the mouth first, going on the side of the mouth. Okay. All right, let's move on. And you can see too, swaddling a newborn. It's on page 293. And look how nice you are wrapping that baby up. And that's how babies like to be. Okay. All right. So, and then the next couple of pages go over about obtaining pulse rate, respirations, and temperature of the baby. And we do this in order to keep make sure the baby's doing okay. So the newborn's pulse is sometimes irregular and rapid, and it can vary from 110 to 160. And blood pressure is lower and may vary with the size of the cuff. So you got to make sure that you have the right size. Now, the average blood pressure at birth is 80/46. So write that down. Remember, I told you to know the newborn's vital signs. The reason I want you to know the normal is in case that there's a scenario on HESI that they give you the the vital signs, and you got to know if it's normal or not in order to what? To answer correctly. So again, the average blood pressure at birth is 80/46, and then the respirations can be about approximately 30 to 60 breaths per minute. Now, daily routine temperatures are taken what? Under the arm. Okay. All right. All right. So again, know the normal vital signs. And let's see. Okay. We weigh the baby at birth, as you probably know, if you've had a baby. And so there is a good picture on page 295 of weighing the baby, and you see the nurse put a little piece of paper down because the baby can lose what? Body heat. Okay, so we do everything we can. You don't want to put that poor baby down on cold scale. Okay, and then on page 294, you can see that maintain the body temperature of the newborn is so important. Okay, so here you want to keep the head covered. Okay, because the head has a very large surface, and it serves as a good source of heat loss in the baby. So put that cap on. Okay, keep the infant covered at all times. Only expose some areas if you need for diapering, or when the nurse does her assessment. I've seen this on our test where a nurse does her assessment, and she's only going to uncover the area she needs to assess at that time. So you can do it in increments. So I want to keep the infant warm. I don't want to cold stress an infant. And then the neonate has small amount of subcutaneous fat. You don't have much fat on him to conserve body heat. And of course, keep infant dry to prevent heat loss by evaporation. And then do not place near a window to prevent heat loss by radiation. We went over this in the last couple chapters, so you might, just review these. And do not place infant on a cold surface to prevent heat loss by conduction. And that's the same thing as putting a baby on a scale. And then prevent drafts to avoid heat loss by convection. Okay, so that's a really good little figure, 12.9 on body temperature of the newborn. Okay, and then next figure, 12.10, is you're assessing the apical pulse. And the best way to do this is with a neonatal stethoscope. They're a little bit smaller, and they go ahead, and it's better. You can hear it better. Okay. Let's move on to circumcision. All right. This is a big area. Usually there's good test questions on circumcision. So you can see figure 12.12, circumcision and ritual circumcision. So A is a circumcision is done either in the doctor's office. They used to do it right in the hospital, but now we don't. They do it more in the pediatrician's office. And the baby's like strapped down, but he's strapped down so he doesn't, move during the time that they're circumcising him. So, and then the other picture, figure B, is about a ritual. It's called a bris. And in the Jewish faith, they have, it's like a party, and in another area of the home, they'll have a rabbi in there, and he'll do the ceremonial circumcision. And it's very nice too. And they can use a little bit of xylocaine cream to apply to the penis prior to circumcision. And because we just went over pain, and we know that these babies do have some pain. Okay, so I wanted you to go over care of the circumcised penis. So this is pretty important, and there's a lot of test questions. Hesse likes them, and you might see that even on NCLEX. Okay, so you want to keep the area clean, and you got to change the diaper. Wash the area with warm water and avoid alcohol. So that would sting. So just warm water. And this is important. So highlight this in your book Do not remove the yellow crust from the penis. Just let it be. Okay, just let it be. It'll come off on its own. And then apply the diaper loosely to prevent the pressure. And you want to tell moms to report any redness and bleeding or drainage. Okay. And then you want to observe for at least 6 wet diapers per day. Okay. So that's the care of the circumcised penis. Because these babies can bleed, because a lot of them are done before the body, his little body, starts making his own vitamin K. That's why we give vitamin K, is so that we help the clotting process. Okay. And that's why a brisk, they don't serve in the Jewish faith, they don't circumcise their young boys until they're at least 7 days old. Okay. Now, care of the uncircumcised penis. So you want to avoid forcefully pulling back the foreskin over the glands, or what we call retraction. Okay, so you don't forcefully pull back anything. You're going to wash the penis with water. And then you may see some white lumps, and that's okay. That's normal. And when the baby gets older and he becomes a toddler, you want gentle retraction after bathing. Prevents moisture collection, because it can get kind of bacteria can get in there. And be sure to replace foreskin after retraction. So if you retract it to clean it, then you want to go ahead and replace it. Under school age, the child can be taught to gently retract his foreskin for cleansing, and this should be done once a week during bathing. Okay, and again, retraction of the foreskin should never be forced, just gentle. Okay, and then you may have the female genitalia, and the thing about that on a little female is that, remember, she's probably got hormones from mommy. So the female genitalia may be slightly swollen, a thin white or even blood tinge mucus, and that's called pseudo menstruation, may be discharged from the vagina. Now it's okay, and this kind of upsets mommy a little bit, but this discharge is caused by hormonal withdrawal from the mommy at birth. Okay, that's all it is. And so that's what you tell them. Okay, you tell the parents, so mommy, to reassure her. The nurse cleans the vulva from the urethra to the anus using a clean cotton ball or different sections of a washcloth for each stroke. And what we're doing, we're preventing any kind of fecal matter from infecting the urinary tract. And you have to make that pretty emphatic to the parents. Okay. Now, let's go on the integumentary. Okay, so now that's what the skin. Okay, so skin turgor, as we know, refers to the hydration or dehydration of the skin. So we want good skin turgor. And they may have these little hairs on their on a term baby, is like on their little shoulders. Okay, and that's just called langugo, and it's normal. Remember, in utero they have that all over their body, and that was to protect their skin. And then they have another thing that protects the skin in utero, is called vernix caseosa, and it's like a cold cream, and it's real thick. And on page 297, there's a visual for you. There's a baby with a lot of vernix on it, and that is a preterm baby there. Okay, so the more vernix they have on the body, that means they were preterm. The less vernix they have would be from term, and post-term they have very little. Where you see it is like in the arm, the crease of the arm, and maybe in the creases around the neck, but they don't for a post-term baby, they don't have very much. So you can see. So the white cheesy cream is to protect their skin while they're in utero. So as they get older in utero, so say they're preterm. So remember, we know preterm, and you go from 20 weeks up to 36 and 5/7. Okay, so If they're 22 weeks, they're going to have more. If they have 26, if they're 26 weeks, they're still going to have more. And as they get closer now to term, they're going to start what? Losing it because it's getting closer to being delivered. Okay. So that's how nurses, when we do our assessment on these newborns, is we see how much Bernex is on the baby and how much Langugo they have on the baby. Now let's just go over together on table 12.2. These are common skin manifestations of the newborn. All right, so look at the first one. That first one is called acrocyanosis. And I just love vision. I love pictures. I don't know about you, but I love pictures. So here you see that you have cyanosis, which is bluing of the hands and feet in the first week of life. And that's caused by a combination of a high hemoglobin and a vasomotor instability. Okay, so that's normal. That's okay. Okay, and so you need to tell mom and dad that this is normal. Remember that. You might see that again. Okay, the next one is cutis marata, and that's like a lace-like red or blue pattern on the skin surface of a newborn. Okay, again, is a normal vasomotor response to low environment temperatures. Baby is what? Cold. So we don't want the red or bluish pattern on the skin surface. That means I'm cold. Hey, wrap me up. Okay. So we should wrap that baby up and get that under, if he's in the hospital, get him under the radiant warmer. Okay, here you have the next picture. It's called desquamization. And what this is peeling of the skin at birth. Now, when you have a post-term baby, this is what you see. Because basically, remember I said post-term, they have less Bernex. So they have very little Bernex. So what happens? Their skin starts to peel and they desquamize. Okay, so what we're going to have is we instruct the parents to avoid harsh soaps. Yeah, the baby doesn't need anything to really take this. We don't want more skin to come off. So we want to, and don't rub vigorously because that would take more skin. All righty. So that's I love pictures. And so that's a pretty good picture there. Let's go on to continue the next page. And now we got some more manifestations of the skin in the newborn. So here you have Epstein's pearls. Okay, so look at the Epstein pearl, and you can see in the picture that there's pearly white pinpoint papillars in the middle of the upper palate. Okay, and you want to distinguish that from what? Thrush. So those are little Epstein's pearls. And then the next one you have erythema toxum. And what this is kind of a splotchy erythema with firm yellow-white papillars that have a red base. And this can occur about age 2 days. And again, no intervention is required because the erythema will clear up. Okay, it's just the erythema is just red. All right, then you have forceps marks, and they don't have any picture there, but I kind of showed you the other day when we did the delivery with assisted devices, how you would have a bruised area of skin in the shape of a forceps or the shape of a vacuum extractor. So these things do happen because the forceps is stainless steel, and so they can get bruising and they're swelling, but they do go down. And again, there is no need for resuscitation interventions other than what? Giving the parents support. All right, then you got the Harlequin color change, and that's an imbalance of the autonomic vascular regulatory system. It has deep red color over half of the body. So you can see that. And changing the position of the infant is helpful. And it does disappear when you have some muscular activity. Okay, the next one is, I would highlight this. This so everybody knows, Mila, M-I-L-I-A. And those are pearly white pinpoint papillars on the face and nose of the newborn. Very popular. So, highlight that. No treatment is necessary, and it will spontaneously disappear. And you just educate the parents not to attempt to squeeze out the white material. Because why? Because infection can occur. Remember, we don't want any break in the skin. Some parents like, oh, I'm going to pinch pimple off. No, you're not. You're not. Leave it alone. It will go away. Now, the next thing, you may see that again. So I would take note to that. And then the Mongolian spots. These are dark blue or slate gray discolorations, and most commonly found in the lumbar sacral area. So see that picture? Okay. Now, their intensity and the color, the depth of the color, remain until fading occurs. Now, it's caused by melanin deposits in dark-skinned people and will gradually disappear in a few years. Nurses must distinguish these lesions from a hematoma or child abuse when they come in. So you have a child that has this, you want to let the admitting nurse know that, yes, my baby has Mongolian spots. And yeah, no cream takes it away. It just basically, it will fade. Okay. All right. And then you have the next one is called nevi, N-E-V-I. And these are like known as stork bites. They're early blanch that can appear on eyelids, nose, lips, and then the nape of the neck, back in the neck, back in the here, the nape of the neck. And basically, they gradually fade, and they don't have any clinical significance, but moms get upset over it. And then you have the port wine stain. And again, these are a collection of capillaries in the skin. It is flat, it's red purple lesions that do not blanch on pressure. Excuse me. So this is a permanent skin marking that darkens with age. Now, again, this is permanent. This is a skin marking that darkens with age and can become elevated and become susceptible to an injury. If a large area on the face or neck is involved, laser surgery may be indicated to preserve the child's self-image. Yeah, and it can be associated with some genetic disorders. So that's pretty hard if you see that on a child, that the parents, they're pretty devastated because it is permanent. Okay. So those are good to know the manifestations of the integumentary system, and I would do that. Okay, now jaundice. All right. When you assess for jaundice, and why do we look at jaundice? Because we want to do a blood test for the bilirubin level. Okay. And so what do you do when you assess for jaundice is that you're going to observe the skin in a well-lit room. Press the skin over the nose or sternum with the thumb until the skin blanches or lightens. And then observe for the level of jaundice. And remember that there's a subcaudal progression of jaundice in term infants. So as the bilirubin levels increases, the jaundice progresses from the head toward the feet. Jaundice can be seen below the sternum, or presence in the arms or lower abdomen or feet may indicate a serum bilirubin test is required. Absolutely. Now, physiological jaundice, as we know, can happen in the first couple of days of birth, and that will eventually go away. You put the baby under ultraviolet lighting and it goes away. Now, pathological jaundice, that occurs in the first 24 hours of life. Pathological jaundice, and that jaundice is never good. Okay, that means that the liver is not functioning very well. All right. So we've got to give the baby fluids. We may have to put him on phototherapy, and make sure that his eyes are covered and his body is exposed to the ultraviolet. Okay, so you just have like a little diaper underneath just to keep him from his little groin area, but you don't want to cover the baby up. No. Okay. So that's a brief little introduction to jaundice. And as we get more into newborn, we'll probably go over that a little bit more and be more specific on it. All right. And then you have the gastrointestinal system. And here is a page 302. You have the different types of stools. All right. So we know that the first stool is called meconium. And here is a picture of meconium. As you can see, that's the first stool of the baby. Remember we talked about meconium staying fluid and the baby having his first bowel movement inside? Well, this is the first meconium stool. All right. That's right. Can you imagine having that inside? The baby's breathing this in. All right. Then you can see that mom breastfeeds. Okay. Do you see what happens to the meconium? It gets a little bit of what? Thinner. It's not so tarry looking. I can equate the first meconium stool to tar. You know, it's real thick. And then you see number 3, the first transitional breastfeeding stool. So it's getting better. Okay, each time mom breastfeeds. And then you go into the second transitional breastfeeding stool, and it's getting yellow, which is nice. And then you have normal breastfeeding stool. That's number 5. And you can see how nice that is. And it's like little grainy, has little grains into it. And it smells better than a formula. Okay. And then they give you pictures of what it is to have a constipated stool. As you can see, it's very little. And then a diarrhea stool. And then, so is it better to moms for breastfeeding? Yes, it is. Always, right? Always, always, always. Okay. Let's just see here. Let me go over some important tips on preventing infections in newborns. All right, so a newborn's response to inflammation and infection is what? Is diminished or slow, all right? And that's because of the immaturity of the immune system. That's why we want these mommies to breastfeed. Then also the umbilical cord is another source of infection. So we want to keep that stump nice and clean and dry. Okay, eventually the umbilical cord will drop off. And when you're diapering a baby that still has part of the cord there, you want to make sure that you put the diaper underneath the cord. So what we do is, you see my hands, I'm just folding the diaper down. And then hand hygiene is always the primary source. We don't want, wash your hands and keep the hands clean. Wash your hands before you touch the newborn. Make sure that visitors come in, they wash their hands, because hand hygiene is the primary means of, you know, we don't want to spread infection. Okay, so wash your hands. All right. All right, and then let me just back up a little bit. I want to go over a little bit about the physiological jaundice, and just let you know that physiological is the normal jaundice. And that scene, we went over the yellow tinge to the skin, and it's caused by the rapid destruction of too many red blood cells. Okay? All right. I just wanted you to know that. And remember, pathological jaundice happens in the first 24 hours. And just like it sounds, if I just say something is pathological to you, you probably go, ooh, right? Yeah. Well, that was my reaction too. Ooh. So that happens in 24 hours. So that means that there's something going wrong with the baby's liver. And so that would need to have further what? Ultrasounds and further lab tests. Things like that are not good. Okay. So let's go over now discharge planning for mom and baby. Okay. Because you got if she's having her first baby, does she need more discharge planning? Probably a little more in depth. Everyone needs discharge planning. And sometimes it's really hard for moms to sit there and listen to all the discharge. And they go, oh yeah, I know that. Well, this is my third baby. Yeah. But it may be your third baby, but you haven't done this in a while. Okay, so I'm going to make sure that I go over everything with you so that you your baby's safe at home, okay, and your baby's well, and so that things go right at the house. Yeah, that's how I put it. All right, so discharge planning. I'm going to include now. Write down discharge planning. Now put down number one. I'm going to go over the basic care of the infant. I'm going to include how to bathe your baby, core care, circumcision care, feeding, and elimination. Important. So this is called basic care of the infant, including how to bathe your baby, how to do core care. Remember, we want to prevent an infection. And circumcision care, we want to make sure this baby doesn't have excessive bleeding, and we want to prevent infection. Feeding, is she breastfeeding? Does she have the entire areola in her mouth and his mouth so that he doesn't cause mom to have sore nipples and cracked nipples, which could lead to mastitis in mom? So we're going to go over feedings. And it's more demanding breastfeeding. So usually they have to feed like every 2 hours. So it's a little more demand because the baby's stomach is very little. So you don't want to overfeed, because if you overfeed the infant, what he's going to do? He's going to vomit. Okay. And then, of course, elimination. We want to make sure these babies have their bowel movements. Okay. And then they know the colors of the bowel movements. So it's going to be from meconium, and they probably have the meconium in the hospital. But if they go home in 24 hours, they're probably going to have another day of that. So they got to know the progression, what happens to the stool. Okay. Now the next thing I'm going to teach them about is safety measures, including the position for sleep. Okay. What? On their back, right? And we're going to go over immunization, and then small groups such as like the La Leche League, that's for lactation. Also, I'm going to probably give her the lactation consultant at the hospital her phone number, and they usually come in and see these patients before they leave, and give them the referral number and everything to call, and they're available 24 hours a day. And then of course they got to take the baby to the pediatrician, a well baby check. And then, of course, the telephone number to the 24-hour hotline for the hospital and the nursery. And then car seats. Well, car seats. Well, they don't have a car seat. They're not going to go home. So they must have a car seat. And then signs and symptoms of problems and who to call. For like a temperature that's up, elevated, like over 100.4, they need to call their pediatrician. If the baby they don't eat, and they refuse 2 feedings, that's very significant. And then of course, if they have like this projectile forceful vomiting, that's not normal, because babies will bring up the excess amount if you try to feed them too much. But forceful or projectile vomiting is never good. And then lack, if they don't void, they should have 6 to 8 wet diapers per day. And so if they're not producing that, then that needs to be addressed. And of course, stooling. And then if they don't stool either, that's another. We don't want them to get constipated or have a problem with that. So that's another indication that something is wrong. All right, so we want to make sure that the nurse should guide the parents in all these aspects: bathing, feeding the newborn, and then ask them, you have any questions? And then make sure that they can demonstrate bathing the baby in the hospital, and diapering, feeding, and changing diapers. Make sure that they know how to take care of the baby before they leave. Okay. Make sure the babies are safe at home. They should have maybe their own little place, little crib with a firm, mattress. And usually mattresses are waterproof. Fitted sheets, they're convenient. Make sure that they don't have any pillows in the crib with the baby. And they usually have these onesies that you can put the baby in, and the baby is nice and warm, And you don't need a bunch of you don't want a bunch of blankets in the crib. No. All right. And then clothing should be soft and washable. And buttons should be sewn or tightly. I like snaps or Velcro on them because they're safer. So when you buy clothes, you need to keep that in mind. So, these are things that the nurse can go over with the parents before the baby is discharged. And, like just like any other patient in the hospital, we always start our discharge planning right there at day number 1. And I go over things. And if I'm going to do a bath on a baby, I'm going to have mom right there watching. Okay. So I demonstrate first the proper bathing. And then what happens is that the next time we're going to bathe the baby, I watch mom do the bath with baby and make sure that she understands it. Same thing with diapering. We don't use any kind of baby powder or anything because the baby can take that in. So we keep away from that. Just make sure that they, wash the baby and apply a nice dry diaper on. Make sure that they know that the diapers need to be changed as soon as they are wet. You don't let a baby stay in a wet diaper. And then on page 305, on figure 12.16, you can see what I was saying before, that the diaper is folded so the diaper does not touch the umbilical cord stump. So you can see that. And again, the umbilical cord is kept dry. And it usually falls off between 8 and 10 days after delivery. And that's what you want to tell mom too. Okay, so they need to be very careful with that because we don't want that to get infection. And then on figure 12.17, you have dressing the newborn. Okay. So like I always say at the end of every lecture, all right, and please read the key points. They're terrific. You have a lot of resources to help you utilize these resources, okay? All right, so this concludes chapter 12. This is care of a term newborn. Next week, we're going to do chapter 13, which we have preterm and post-term newborns. And it's a little bit different when you have a pretermer and a post-termer. Okay, there's certain, things that can happen with these babies. So we have to be on alert to it. Okay, I hope you enjoyed today's lecture on chapter 12. And keep reading, answer the questions, and I'll see you next week. Okay. Have a good weekend. Keep studying, everybody. Thank you. Bye-bye now.